Good morning. This is Dr. Dapapgliflozin, Senior Consultant Interventional Cardiologist and Director Cardiology at the Supreme Hospital, Delhi NCR. I have spoken on dapapgliflozin and the role of an SGLT2 inhibitor in patients with heart failure. The reason is that heart failure is almost like a pandemic in the world. There are millions of people, there are lakhs of people with heart failure. And the prognosis is pretty grim once a patient has developed heart failure. Heart failure is not a stable condition, it is progressive. The person concerned, the patient, may appear stable and in control, but actually the disease is progressing, and that is the reason, despite medical therapy, almost 50% need a readmission because of heart failure within 1 month, and around 20% die within 2 years. So you can clearly see that the prognosis is not very nice once a person has had heart failure. Over the last few decades, there has been some treatment which has been found in randomized trials to be effective, and these drugs do reduce mortality in patients with heart failure. A beta blocker would reduce mortality by almost 35%, which is excellent. A mineralocorticoid receptor antagonist would also reduce mortality by 30%. An ACE inhibitor or an angiotensin receptor blocker would reduce mortality by 20 to 25%. So we did have drugs that helped in patients with heart failure, but yet, as I mentioned a little bit earlier, patients were still getting re-hospitalized within a month, and a significant number of patients were dying within 2 years, despite optimal medical therapy. It was against this background that in 2014, that a landmark study was presented. This was the Paradigm heart failure trial. This was the largest heart failure trial then, and I think even till now, more than 8,400 patients with heart failure with a reduced ejection fraction of around 29% were randomized either to a compound called ARNI or to enalapril. Now, enalapril is an ACE inhibitor. The dose used here was not exactly the best, but it was 10 milligrams twice a day in one group, and in the other group, the drug used was an ARNI. An ARNI is an angiotensin receptor neprilysin inhibitor. That means there are two drugs within this drug. One is Valsartan, which is the angiotensin receptor blocker, and the other is Sacubitril. Sacubitril is the neprilysin inhibitor. Now, what this does is it raises the levels of certain peptides which are called natriuretic peptides. These produce a little bit of diuresis. They release some water from the body, and apart from this, they are believed to prevent or arrest the fibrosis in the failing heart, and also to increase the parasympathetic activity and thereby reduce sudden death. Now, in this study, the Paradigm heart failure trial, which had, as I've just said, more than 4,400 patients of heart failure with a reduced ejection fraction, these patients were followed for almost 27 months, and then there was a robust difference in mortality or cardio or admissions for heart failure. This was to the tune of 20%. So there was a significant 20% reduction in cardiovascular mortality or hospitalization for heart failure in the patients enrolled to or randomized to the ARNI. Now, the important thing to remember here is that ARNI was not being compared to a placebo. The so-called control group had actually a drug being delivered to them, which has been known to be a successful drug in patients with heart failure, and this was enalapril at a dose of 10 milligrams per day. Apart from this, there was also a reduction in deaths to the tune of 16% over these 27 months in patients given the ARNI. So, this was certainly, to a large extent, a landmark trial. We had another drug, if when given to a patient at a dose of, we begin with a dose of 50 milligrams twice a day, built it up to 200 milligrams twice a day. This was supposed to be the maximum tolerated dose. Then we would have these substantial effects of improved survival and a reduction in hospital admissions. Apart from this, there was also another study with an ARNI. This was on 800 patients of heart failure with a reduced ejection fraction. These 800 patients were followed for almost a year, and it was found that there was an increase in ejection fraction by almost 9.5 absolute percent. Now, this is a remarkable increase in ejection fraction. This is comparable to an ejection fraction increase when we implant a biventricular pacemaker. Also, we found that there was a very rapid decline in the NT-proBNP levels, and this was as quickly as within a week or 2 weeks from onset of treatment. So we found that not only was there a reduction in mortality, not only was there an improvement in quality of life, and also we had a reduction in the rate of hospital admissions. We also find that the mechanism could be this reduction in the heart size with a significant improvement in ejection fraction. Now, of course, this drug was found to be effective, but it has not penetrated the market even now. Even now, we have just about 10 to 15% of patients with heart failure who are on an ARNI. And I will have to again reiterate that the recent studies have shown that another class of drug is very effective. This is an SGLT2 inhibitor. I have already spoken about the DELIVER trial, which was a trial of patients with heart failure with a preserved or a marginally or a mildly reduced ejection fraction. Here again, there was a reduction in mortality or hospitalization by almost 20% in a follow-up of about 2.5 years. With dapapgliflozin, which is an SGLT2 inhibitor, the dose here was used, was 10 milligrams per day. So what do we do now? If we get a patient with heart failure, whether it is a patient of reduced ejection fraction or a preserved ejection fraction, that is an ejection fraction of more than 50%, the best approach would be to start 3 or 4 drugs simultaneously and build up their levels. These would be a beta blocker, a mineralocorticoid receptor antagonist, an ARNI, that is this combination of sacubitril with valsartan, and of course an SGLT2 inhibitor. The way I remember it is using the acronym AB, A for an ARNI, B for a beta blocker, and medical superintendent, MS, that is a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. Thank you very much. I hope I have tried to make this very difficult subject of congestive heart failure and its treatment, made it simpler, and have summarized the big studies, and have explained to you what should be the best approach, because it is said that if all these 4 drugs are employed, then there could be a reduction in mortality of almost 75%. Thank you very much.